Hello. Dayami and let's see if
Yeah,
Kyle's
I'm
on
here,
here.
I'm
Did
here.
you receive the resend of the intro paragraphs I just sent?
Oh, no, I'm just gonna go and check. Yeah, I just got the recent.
Hey, everybody. It's the Ideas Forum again. Glad to see everybody joining us, and we are waiting a few more minutes just to see, because I see people continuing to come in to the chat, so in the forum. So we'll just wait a few more minutes, and then we'll kick off with Melissa and introduction by Kyle. And while we're waiting for more to join and just give it a few more minutes, I just want to remind everybody yet again, if you haven't heard from multiple sources, that next month, instead of the Ideas Forum, we're having our Slam Dunk Conference, which really stands for Symposium for Learning about Alzheimer's Disease-Related Medical Research at Duke-UNC. Don't you think slam dunk is quicker? Whoa, that's a mouthful.
Yeah, I worked really hard on that acronym. I think it's hopefully I'll have better contributions later, but so far I think it's my best contribution to the Duke and
So
UNC
I think, Kyle, at
ADRD.
4:05, we should get launched, okay?
Yeah. Yep. Sounds good. We'll get ourselves
Can't hear
going.
you.
Oh. All right. All right. Can you hear me now? Yeah. Melissa can hear me. Okay. She's shaking her head. Yes. All right. Great. All right. So I'm going to introduce Dr. Melissa Harris. She's a registered nurse with PhD, and she has 8 years of clinical experience working with older adults in a variety of mental health settings. Many of these adults also have co-occurring diagnoses of dementia. She mentions that it was the inpatient psychiatric setting that she first observed how individuals living with dementia and their care partners can often fall through the cracks of the healthcare systems, and that this sparked an interest in conducting research to find solutions for families living with dementia. So Melissa received her PhD in nursing from the University of Michigan, and she's a postdoctoral fellow here in the National Clinician Scholars Program at Duke University, as well as the Durham VA. Her research focuses broadly on quality of life and care of individuals and families living with dementia. Specifically, she's interested in developing, testing, and implementing interventions to help families better manage stress at home. She's one of 3 inaugural REC scholars, and her REC scholar project is titled Development of a Home-Based Dyadic Stress Management Toolkit for Dementia Caring Dyads. So we're really thrilled to have her as one of our new REC scholars, and excited to hear a little bit about her project and more about her research interests today. So with that, I'll turn it over to Dr. Harris.
Thank you, Kyle, for the introduction. You should be seeing my slides. Let me know if not. I'm very excited to have been selected as an inaugural cohort member of the REC Scholars Program. I'm very excited about this project, and I look forward to any feedback that you have at the end. But to begin, we know that stress-related symptoms, including behavioral and psychological symptoms of dementia, are highly prevalent and also very burdensome for people diagnosed with dementia, but also care partners and caregivers, because they're associated with increased stress that caregivers experience. These stress-related symptoms are also very costly to the US healthcare system, because they account for up to 30% of the dementia-related healthcare costs in the US. Despite the prevalence and the impact that these types of symptoms have on people living with dementia and also families and society, they remain very difficult to manage, and non-pharmacologic interventions have been recommended as the preferred method for managing stress-related symptoms in dementia, but they've had limited uptake in the community and also by healthcare systems. This is likely due to the fact that many of these non-pharmacologic interventions are multi-level, they're multi-component, they can be very complex, very costly, and in many cases, they add burden on the caregiver who may already be experiencing high degrees of burden. We know that simpler stress management tools exist that people can use in the home setting, but there's been limited research that actually focuses on use of such tools by individuals with dementia and also caregivers and care partners. So a dyadic toolkit that consists of several different stress management tools that can be used at home may be a promising approach to improving stress management for families living with dementia or dyads of people living with dementia and their care partners. And when I say tangible tools, this is what I mean by the types of tools that could be used to help manage stress. So things like robotic pets and baby dolls, there's such thing as dementia-friendly music devices, guided journals for caregivers. At the bottom left, that's an acupressure tool. There's also massage tools to help with stress, Aromatherapy devices and bright light therapy devices, and also weighted blankets are just some examples. What these tools have in common, though, is that they're all relatively simple to use and they're passive in nature, which means that they put very limited burden on the user to actually use these tools in daily life. In addition, all of these tools have demonstrated high degrees of safety of use in older adults. So through my dissertation research, I led 2 studies to kind of inform the proposed POT project. The first study was a qualitative exploratory study. I conducted focus groups with 7 persons living with dementia and also semi-structured interviews with care partners. And the purpose of this study was really to better understand the stress experience of individuals and care partners who were caring for somebody with dementia or who were living with dementia, and particularly their stress experience at home during the pandemic, because this was conducted in the early stages of the COVID-19 pandemic. Some of the key findings were that the stress experience of the person living with dementia was often interdependently related with that of their caregiver and care partner. So it was very difficult to separate the stress of the person diagnosed versus the stress of the care partner. In many ways, they were occurring in tandem. Another key finding was that families expressed a strong need for in-home care strategies to help manage stress even before the pandemic began. But because of all of the restrictions placed on healthcare and also supports in the community during this time, that need was amplified. And so in response to having limited access and support in the early stages of the pandemic, another key finding was that families were really being innovative in how they manage stress at home, and they were finding new ways to help their loved ones with dementia manage stress as well. So we have a lot to learn from these families. The second study of my dissertation was a feasibility and acceptability study looking at the use of weighted blankets by persons living with dementia. If you haven't seen or heard of a weighted blanket, it's like a traditional comforter, but they typically weigh between 10 to 15 pounds. So they have added weight to them, and they're meant to have a relaxation effect. This study was a within subjects pre-post design. 21 dementia caring dyads participated in the study. And overall, the study demonstrated really high degrees of feasibility of using a weighted blanket every day at home, and also remote delivery of the intervention, because this study was occurring in the early stages of the pandemic. In addition, there were high degrees of acceptability. So the persons living with dementia and the care partners felt like the weighted blanket was something that fit well within their routine. However, there were a few persons living with dementia who did not find the weighted blanket to be very beneficial. They did not use it for the recommended once a day. I think we are recommending at least 20 minutes a day of weighted blanket use throughout the 4-week period. Some of the persons living with dementia were not able to complete this, which suggests that there was some barriers to use for certain individuals. Another key finding was that we were looking at the feasibility of collecting a number of different person living with dementia specific measures and also caregiver specific measures. But the persons living with dementia really had difficulty in completing some of those measures that were completed by self-report. So how these findings are going to be informing the proposed study. First, the finding related to the interdependent nature of stress that people living with dementia and care partners experience suggests that a dyadic approach is likely needed to really optimally manage stress for these families living at home. In addition, given that the weighted blankets fit well within routines of most, but not all persons living with dementia, a single tool is likely not enough to really make a dent on the stress experienced by dementia caring dyads. I like to say that I don't believe that any one tool is a magic pill. I don't think any one tool is going to work for everyone, but having several different types of tools may be an approach to better managing stress at home. And finally, because we did observe some difficulties in collecting measures by self-report from persons living with dementia, it's likely that we need alternative measures of stress to really capture how these interventions are impacting the stress experienced by persons living with dementia. So the aims of the proposed study are first to develop a prototype of a dyadic stress management toolkit with and for persons living with dementia and their care partners. And I say with and for because we'll be using a human-centered design approach that really engages persons living with dementia throughout the intervention development process, as well as their care partners and caregivers, because it is a dyadic focused toolkit, or meant to be. The first phase of the human-centered design process is really to identify and better understand the experiences of the target population in order to define the problem. And we've done some of this work already with the 2 studies that I presented previously. So we'll be moving into the define and design stage of the human-centered design approach, which involves co-designing solutions with stakeholders. And the stakeholders in this study will be individuals living with dementia and their care partners. And the co-design process will involve multiple ways of engaging these stakeholders to inform development of the toolkit. And then aim 2 is to user test the stress management toolkit intervention that's developed through aim 1 with at least 10 dementia caring dyads. And that is to address the validation stage of the human-centered design process. Aim 3 is then to explore the feasibility of collecting a number of stress-related outcome measures in persons living with dementia, as well as their care partners. And this includes stress-related participant-reported outcomes and also salivary cortisol biospecimens. And the reason this aim is important is really to inform measurement selection for a future study, and that will look at the efficacy of the toolkit if the findings warrant future testing. And it's also important because prior non-pharmacologic intervention studies have in fact used participant-reported outcomes to measure the impact on stress in this population, but they've also often focused more specifically on the physiologic and the social impact on those components of stress. Few studies have looked at the actual physiologic impact that these non-pharmacologic interventions have on individuals living with dementia and care partners. And I think by looking at the biologic impact, we may have a greater understanding of efficacy of these interventions. So aim 1 will be addressed using a qualitative exploratory study, and we'll be conducting 4 focus groups with dementia caring dyads, about 3 to 4 dyads per group. They'll be recruited through several community support organizations, including Dementia Inclusive Durham, the Duke Dementia Family Support Program. I also have connections with a national organization that helps persons living with dementia identify new ways of advocating and educating, and that's the National Council of Dementia Minds. So that may be another organization to identify individuals that can help engage as stakeholders in this project. The focus groups are going to be held either over Zoom or in person. And one key piece of my dissertation work was that I learned that families really like having options to engage in research. So having Zoom options as well as in-person options may increase willingness to participate. And then we'll use rapid qualitative analysis to analyze that data in order to inform development of the toolkit. And so I can talk a little bit more about the data collection and the rapid analysis process. The groups will be audio recorded and transcribed using Zoom transcription services. And we'll also have a research assistant taking very detailed notes throughout each of the groups using a semi-structured note-taking guide. And together, the research assistant and I will then form these post-group summaries of the focus groups of the key points that really come out of each group. And together we'll code that data using a code book. And I believe we'll be using predefined categories related to intervention development to identify key pieces, components of the intervention, the types of tools that can be included, as well as components of the user guides as we do our coding. And that coding process and identification of key categories can be used to inform the development of this toolkit prototype. And then as a final step, we'll obtain feedback from at least 2 of the participant dyads that participated in the focus groups to finalize the prototype. And some steps that we'll take along the way to really ensure that this process is successful. We'll have a number of strategies to really engage the persons living with dementia in those focus groups. So this may include taking breaks throughout the focus groups if needed, having very targeted questions for the persons living with dementia to answer, and also offering the opportunity for them to just brainstorm on their own without much guidance, if that is what they feel is appropriate. We'll also use purposeful data reduction, which means techniques, which means that we'll really focus on the data that's most likely to support the development of the toolkit. I imagine that there will be a lot of qualitative data that comes out of this project. Some of it may be useful for a later secondary data analysis, but then some of it may be more useful to really just hone in and develop that toolkit. And that is the data that we'll focus on in this phase. The data analysis and also the feedback process with the participant dyads will be ongoing and iterative. That's the nature of the human-centered design approach. And this also means that we may need additional focus groups or potentially one-on-one interviews or dyadic interviews to really finalize the toolkit prototype development. And then once we have a prototype that we feel like is ready to go, we do move into the user testing phase. So 10 dyads will use the toolkit at home for at least 2 weeks, and we'll obtain feedback through questionnaires and focus groups. And the feedback that we'll be looking for is the usability of the toolkit, so the frequency of use, the feasibility of the toolkit, and to measure that, we'll look at enrollment and withdrawal rates, and also any adverse events and injuries. We're also interested in looking at the acceptability of the toolkit from the perspective of the individuals diagnosed and also the care partners. So we'll be looking at satisfaction and benefit with the toolkit. Both members of the dyad will provide consent to participate in this study, and we'll aim to enroll and begin baseline data collection with at least 3 to 4 dyads at a time. And so that is that, so that at the end we can convene a focus group and we'll have enough dyads for a focus group at the end. Baseline data collection will occur within 1 week prior to that user testing phase. We'll collect sociodemographic information and also the stress-related outcome measures, which I'm going to go over in more detail in the next slide. The toolkits will be delivered to participants' homes, and then they'll be able to participate in a Zoom session or telephone session with a research team member to review the different components of the toolkit, how to use the different tools, and also the safety features of each tool and the corresponding user guides that are developed through AIM-1. And the user testing phase will be 2 weeks. Halfway through, we'll look at the frequency of use of the toolkit by the participants using a questionnaire. And at the end, we'll collect post-data collection, including measures of usability again, as well as acceptability and those stress-related outcome measures. And after those measures are collected, we'll convene a focus group to really take a deeper dive to better understand what went well and maybe what didn't go so well during the user testing phase of the toolkit. And we'll also collect those measures of feasibility throughout the study. And these are the stress-related outcome measures that we'll be collecting at baseline and at the end of user testing. So the ones highlighted in blue are the participant-reported outcome measures. The neuropsychiatric inventory will be measured will be used to measure neuropsychiatric symptoms of dementia. And this is a questionnaire that's completed by the caregiver, and they reflect on the person living with dementia's behaviors and symptoms over the most recent weeks. Caregiver stress will be measured using the perceived stress scale. Again, this is a questionnaire completed by the caregiver. The dyadic relationship scale is completed via questionnaire by the person living with dementia and also the caregiver. And this is a measure of dyadic relationship strain. So it's important that we're able to capture the perspectives of both the person diagnosed as well as the care partner. And again, thinking about offering options, these questionnaires will offer the opportunity to complete them via an electronic survey, but they can also be completed either verbally by telephone or by hard copy, depending on the participant's preference. And then finally, the measure that I'm most excited about, but probably have the least experience with, is the measure of physiologic stress, which will be collecting salivary cortisol biospecimens to measure cortisol as a biomarker of stress. And we'll be collecting this measure from the person living with dementia and then also the caregiver. And we'll be asking them to collect these samples on their own in their own homes. And I'll talk a little bit more about that process in the next slide. But for all of these measures, data collection will be considered feasible if the participant completion rates are greater than or equal to 80%. In terms of the collection of the salivary biospecimens, I've been working with the Duke School of Nursing Biomarker Lab to develop this data collection process. We'll first mail the oral swab kits that are from Salmonectric's lab to the participants' homes, and then they'll receive ongoing education and support either by phone or via Zoom on directions on how to collect those samples. And we're collecting samples at baseline and at the end of the 2 weeks of user testing. We'll be asking each of the participants, so the person living with dementia and the care partner, to provide 5 samples collected within the same day at baseline and at the end of user testing. The minimum amount of samples that you need to really do a cortisol analysis, from what I've learned, is at least 2, but the more samples you have, the better. And because this is a feasibility study, we'll be looking at aiming to collect the maximum of 5 samples. I don't believe we'll actually be able to collect that many samples in each participant, but hopefully the findings of this study will be able to give us a range of what's optimal for people living with dementia and their care partners to be able to collect in a future pilot study. The participants will then store these samples in their home refrigerators, and we'll provide them with an envelope and an ice pack to be able to return those samples to the Doosan Biomarker Lab. And again, the focus here is really looking at the feasibility of collecting these samples. However, the Doosan lab can store those samples for later analysis if needed. And the expected outcomes of this work is that we will have a working prototype of a dyadic stress management toolkit intervention, as well as data to support the feasibility and acceptability of the toolkit. We will also identify areas to really refine and improve the design and delivery of this intervention. In addition, we'll have measures identified that may or may not be able to be used in a future pilot study, and areas to improve the future design of a pilot study in terms of recruitment, as well as measurement selection and data collection methods. The potential impact is that these findings can inform the development and the preliminary testing of the toolkit intervention. The hope is that by using the human-centered design approach and really engaging families at the onset of development, that this may increase the feasibility and acceptability of the developed intervention. And this is with hopes of potentially implementing this intervention and having it more have an increased likelihood of being sustained in the community or by healthcare systems. And the Rec Scholars Program will be supporting multiple aspects of this study, but kind of most broadly, the experience in leading this study and also the data that results from it can be used to support a future pilot study grant application or a career development award application. And because I do have a strong interest in staying in the area after my postdoc, the cross-campus connections are going to be very important for me. I think the stress toolkit also has a lot of applicability to rural dwelling families because there doesn't require a lot of in-person education or interaction. So I think the connections with ECU specifically could help reach families that are rural dwelling. And finally, multiple cores within the ADRC are relevant to this study. We're certainly collecting multiple types of data, and it's not really a big data analysis project, but because we have qualitative data, quantitative data, and that biologic data, having support from the biomarker core and the data management and statistics core will be helpful. And of course, recruitment for this study from the clinical cores and the outreach and recruitment and engagement core. But thank you all so much for your time. Like I said, I'm just very excited for this project and for your feedback.
Thank you so much, Melissa. That's great. I think we have time to do maybe 5 minutes of questions now, and then we'll go to the next speaker, and then we can do questions for them and any additional questions that might come up. I saw Ellen posted a quick question in the comment, and then we'll go. Eric's got his hand up. So Ellen asked, we'll mention that, if you asked if you'd thought about if the envelopes already are pre-posted, right? And I think we had talked about that as well, because we've done similar things where the actual act of getting postage on them is a major limitation, right? And then wanted to know how quickly after collecting the last sample they need to mail and return them.
I haven't thought a lot about when they actually return them. I was thinking we would provide the envelope and the ice pack, and they would return it after the baseline collection at the end the next day, if possible, and then another envelope at the end of the post data collection. I don't know how long they can stay in the fridge. So I don't know if it would be best to wait till the very end, but I had it in mind to collect them twice and have them send them twice.
See, Eric, did you have a question you want to ask?
Yeah, I thought it was interesting that you were struggling with the self-reporting, and so I was just curious if you could speak a little more about what measures you were using and then what didn't go well.
Yeah, so from the perspective of the person living with dementia, we collected the quality of life and Alzheimer's disease scale, and then the other one was, oh, now I'm gonna blank. Oh, the rating anxiety and dementia scale. From what I understand, I think part of the problem was that because this was all virtual, we did run into issues over Zoom with trying to engage the persons living with dementia and keep their engagement throughout the measurement. We mailed hard copy examples and we pulled up response options on our screens, but in some cases that was just not enough for the person living with dementia to be able to answer some of the more detailed questions. I've talked to people who have used these measures in person and they had better luck, especially because they were able to take breaks and kind of come back to it a couple of minutes later. So I think the in-person collection could be a solution, but I also know that for some families, they prefer Zoom and telephone. And I still, in my mind, at least, I appreciate offering options, but I think that just means that we may have some more missing data than we would if it was just all in person. But I welcome any thoughts if other people have different experiences with collection over Zoom or phone.
Melissa, on that, we just finished a CDC focus group with older adults. So there was not dementia, but it was with older adults on deprescribing benzos and opioids. And we were originally going to do all our focus groups in person. And then, of course, COVID hit. And we did research, and so far we have found really no difference in the validity of the information if you use Zoom or in person. Now, I don't know if that will be more problematic with your dementia group, probably not with the caregiver part, but that's what our research was, and we went ahead and did it, and we had good results. There were a few people who didn't know how to use Zoom, and so, or had difficulty. So we ended up doing those on the phone, having them call in the Zoom number so we could still record it on Zoom and use the transcripts. So that's another thing to think about if you can't, another way to use Zoom through the phone, because you can record it.
That's a good point. Yeah, I learned that about halfway through my dissertation, that I could just have them call into the Zoom and not call from my personal phone. So, but no, I foresee we may still have some issues with collecting the data from the persons living with dementia. But in terms of collecting the caregiver completed measures, I don't foresee that being as big of an issue.
Great. So I guess I was curious, I think the idea of piloting biomarker collection for response it was something I was very excited about in the proposal. I think cortisol is a very reasonable one to start with. If you had sort of a bigger sample and, like, let's say R01 level resources, are there other biomarkers that you'd be interested in or consider? Obviously pending feasibility, but assuming you can get some decent things at time points.
That's a good question, and I probably haven't given enough thought to it. And I am a very pragmatic thinker, so I'm always thinking, what could we actually do? And then what's unreasonable to ask? The one that I think is reasonable to ask of participants, and they may have buy-in to, is heart rate variability. I think you can look a lot at least individual changes in stress by looking at heart rate variability. I don't really have a good understanding of how data is analyzed when you have multiple heart rate variability strips from somebody, but that's another measure that I've considered that I think could be feasibly collected in this population. But I have a lot to learn when it comes to biomarkers and what options are out there.
That's great. Well, at least you didn't say, oh, CSF. Let's just do spinal taps on everyone, right? Like, the pragmatism is important.
And I just have one more question. Is your biostatistical resource covered? Do you have that because you were looking at using the cores, or is that another need that you're going to need, like a statistician to help you?
I don't imagine needing a statistician for this project. I feel equipped, and at least I could find support elsewhere for it. I think we'll see, but the data I don't think will be too complex for me to be able to do the analysis.
Thank you.
Well, thank you so much, Melissa. Jan, Dami, you were going to introduce our next speaker, correct?
And I was just going to congratulate Melissa.
Oh, yes.
Very nice presentation.
Thank you. Thank you all for the feedback.
Yeah, I'm supposed to introduce the next speaker, and actually, this speaker is also inaugural record scholar for this for the center. Is Dr. Ling Wood. Dr. Wood received her medical degree at Conard Medical University and has her residency in psychiatry at the Shanghai Mental Health Center in China. She obtained her PhD in regulatory biology from a joint program at Cleveland State University and Lerner Research Institute of the Cleveland Clinic Foundation, and did postdoctoral research training with focus on cardiovascular diseases at the University of Washington Medical Center. She joined the Bright Research Institute, NC Central, as a research assistant professor last year. Over the years, she had been performing disease-related research, including diabetes, cardiovascular diseases, and most recently on Alzheimer's disease. She has published over 2,000 papers with significant experience in clinical and translational research. Her Alzheimer's disease and Tauopathies work focus on new biomarker discovery and development to be used for early diagnosis, disease diagnosis. So without further talking from my part, I'm gonna let her talk about her project.
Thank you, Dr. Lopez, for the introduction. I'm very excited to be selected as a REC scholar. The topic for my study is about developing new biomarkers for Alzheimer's disease and the related Tauopathies diagnosis. So here's it's outline for my today's talk. What's the Alzheimer's disease and the tau phosphorylation in AD and the biomarker detection in AD, and how REC will support my career development. First, I would like to introduce some background about the Alzheimer's disease. According to the DSM's 5 diagnostic criteria, neurocognitive disorder due to the AD is characterized by insidious onset and gradually decline in memory and learning, and no evidence show other etiologies like the neurodegenerative or the cerebral vascular disease. For example, the Lewy body disease, FTD, and the stroke, major depression. AD is the most common cause of the dementia among the older people around the age 65 or older. The control may contribute to 60–70% of cases, dementia cases. Secondary is the FTD. So currently in the United States, as the age 65 years older group, there are around 6.5 million people suffer from the Alzheimer's disease. In Europe, the amount is around 9.7 million over the world. So it's around 55 people. This number is expected to be doubled by 2050. So obviously, this will give the society, the family people and the family members and the society a huge burden. So far, this one is no cure. So what we can do currently is to find the early and give the early intervention. So far, postponed the AD dementia development. The pathological changes of Alzheimer's disease, including the actual A-beta amyloid plaques here, and the intracellular, the neurofibrillary tangles. This formed by the tau aggregates. So my project will focus on this protein. These pathological changes will cause the neuron death and finally cause the brain atrophy. So the function in the correlated brain regions will be affected, including the memory, learning, language, emotion, behavior. At the end stage, the individuals cannot perform the daily activities independently. Like they need help for the eating, dressing, and working and bathing. So finally, they need a long-term care. So here I would like to introduce another concept for early AD dementia. We call that mild cognitive impairment, MCI. So during this early stage, the individuals may have a memory loss. We call it amnestic. All the other cognitive ability loss, because of non-amnestic. Such that people cannot have the effective conversation, or sometimes they cannot find a way to go back home. They cannot pay a bill, but at least during this stage, they still can perform the most of the daily life activities. So usually it's noticed by only noticed by the family members and the close friends, not by other people. So there are around 12% to 80% of people at age 60 or older, they're living with MCI right now. So within the 5 years, 1/3 of them will develop the AD dementia. Within the 10 years, they're around 50% of the MCI will develop to AD dementia. So if we can make the early diagnosis for the MCI and provide the early medical intervention for this period, so we can postpone or stop the AD progression. This will largely improve life quality and reduce cost of nursing home and long-term care. So right now, the clinical diagnosis for Alzheimer's disease is largely based on the symptoms to check whether they have the memory loss or that they have a difficulty in learning. If the patients have the genetic background, so they will do the genetic screening. This includes these genes like APP, presenilin 1, 2, and ApoE. Combined with other clinical examinations like a structural MRI, PET scan. Recently, developed some biomarkers that testing the CSF and the blood. This include the A-beta-42 and the total tau and the phospho-tau. But so far, there's no MCI biomarkers available. So new markers are needed urgently for the clinical diagnosis. Also, the pre-existing currently using the biomarkers like phospho-tau 181 and 217. The specificity and the sensitivity is pretty limited. Also in our study, we also test these biomarkers. So our studies focus on the tau phospho-tau. So it's well known that hyperphosphorylation of tau can cause the tau aggregations, can form the tau neurofibril tangles. So this aggregation tau aggregation can spread from the hippocampus to neocortex, then finally cause a neural death and cerebral atrophy, and in turn cause the cognitive decline. So the neurodegenerative disease with the tau deposition in the brain, we call tauopathies. So the tauopathies include the AD and the Pick disease, short in the PID, cortical basal degeneration, short in the CBD, and the progressive supranuclear palsy, short in the PSP. So a good phospho-tau-based biomarker should be able to differentiate the AD from other tauopathies. So our project will cover this differential diagnosis. So Dr. Steam's research group uses proteomics to map the tau phosphorylation size and the frequencies in the AD brain and the normal brain. Here I just list the frequencies over 30% here. We can see here the most of the phospho-tau sites are located in the protein-rich regions, filled in the C-terminals. So we screened the 2,000 of the antibodies against these phospho-tau sites, including the red labeled phospho-tau sites in brain tissue by Western blot and ELISA. Here's some example results. I use one as examples. This phospho-tau S198. So the upper high molecule weights tau aggregates represents the tau aggregates. We can see this part high molecule weight smears only show up in the AD and not in the controls. Also not much in the other tauopathies, PSP, CBD, and Pick disease. So we test several, including the existing clinical use biomarker, phospho-tau 181 and phospho-tau 2T217 and 231. So we validated they're all good for differentiated from the AD differential from the control and the other autopsies. We also have a new ones, the S198. It's good. Also the 202 is okay. This one is okay for the AD differential diagnosis from the other topics. So this one is not very good. So we also have several other very good ones. So we're not just a limited time. So I'm not going to present here. So in order to validate our the very simple results, so we performed the ELISA. So here again, I use the S198 as an example. So use the pre-existing the biomarker as a control comparison. So left panel is a scatter plot. Middle is one the bar graph. This one is the RC curve. So we can see for our new one was the existing 181, 217 and 231. They all have a good separation from the control and AD and other topics. Significance here. That's also we calculated the AUC, the area on this curve. Here's this value is between the 0.9 to 1 is very good. Show that means this biomarker has the high sensitivity and specificity. 0.8 to 0.9 is good, 0.7 to 0.8 is fair. So they all, our new one, also the clinical use pre-existing one, biomarker, they all have the pretty good AUC. So most exciting is our new one when we tested in the MCI samples. So these ones perform better than the clinical use biomarkers. See, we always use the AUC 0.8. Others, this one shows 0.74 here, but it's kind of, even lower. So it doesn't make any sense. It's what statistically shows a no significant difference. This two also it's kind of low. It's lower than ours. So based on our premier data, so we identified several potential phospho-tau biomarkers. So we only want to show one new one here, but we also have several others. Ours with high specificity and sensitivity and differentiating the MCI from the cognitively normal subjects and the AD from the other tauopathies. So from our study, we use a sample size relatively small. Also, we use the post-mortem brain tissues. Also, when we switch our testing in the CSF and blood, we didn't detect any signals. So here comes questions. So whether our sample size is enough to validate this our biomarker. Second is whether we can detect the potential biomarkers in the CSF and the blood. So due to the low abundance of phospho-tau in the blood and the CSF, so we need to seek for more sensitive detection method. So thanks for the high-tech development. The industry, the Quanterix, they developed the ultra-sensitive small techniques. It's called a single molecule array. So this method is increase the sensitivity 100 times more, comparing the classical method, ELISA and the Western blot. So ELISA and Western blot only can detect signals on the nanogram to picogram. So this one can detect to femtogram. So here's the workflow for this method. The tiny amount phospho-tau in the plasma and the CSF combined to the pre-coded magnetic beads with the capture antibodies. So after adding the detection antibody and the enzyme, so the whole loading, the whole complex will load it to the small disk. This small disk is a special design with a very tiny small holes. One hole holds only one single molecule. So that's why the sensitivity is very high. So after adding substrate, the fluorescent signal will be detected by the machine, and the computer will analyze the results. Based on the previous preliminary data, so we hypothesized the site-specific phospho-tau sites detected by our Western blot and ELISA in the brain tissue. They are the novel markers for AD diagnosis and the disease differential from other tauopathies. Our long-term goal is to develop an easy-to-use and low-cost AD test with high sensitivity and specificity. So specific aim one is to test our biomarker with the larger sample size, brain sample size, and then we are extended to the plasma and the CSF. So first we'll confirm our finding by increasing sample size, and second is collect the more CSF sample, blood samples. A third one, we will develop an ultra-sensitive detection method. Next, just called SIMOR. So this one we test in the CSF and blood. Our second method is we are trying to identify and develop the phospho-tau markers for MCI and test the potential markers in the CSF and the blood from the MCI patients using the similar techniques. So how the REC and the ADRC may support my career development, which this one can help to develop a significant collaboration with the several Duke-UNC ARDC core. Because we need to collect the clinical samples, we hope to collaborate with the Dr. Jerry Wang in Duke and Dr. Andy Liu in Duke for clinical call for blood and CSF samples. So we'll work with Dr. Zhu for the new technology development as a similar test. We may collaborate with the research education component for increase some student training or networking. Also, when we deal with large sample size, we may need to collaborate with the biostatistical in the Duke. Later, maybe in the future, we can some collaboration with biomarker core. So I would like to thank all the lab members in Dr. Xu's lab, and thanks for our collaborators, Eric Wang in the Duke pathology and Andy Liu in the neurology in Duke, and Dr. Zhu in the Case Western, and Dr. Georgie Bloom and Dr. Zhang in the UVA. Lastly, thank you all for your attention. Any questions?
I have one question, Ling.
Yes.
So will you be needing statistical support from the ADRC then to help you with that large data for analyzing your data?
Yes, we made it later. So when we work on the R1, so we need them.
Okay, we're just gonna note that and let the principal investigators know that you will be needing statistical support.
Yeah, that'd be great because I don't.
Okay,
Yeah,
thank
yeah.
you.
Thanks.
Yes, I was curious, are you thinking about the phospho-tau MCI biomarkers more as sort of predictive prognostic, or thinking about them in terms of like a surrogate endpoint, like clinical endpoint for therapies, or I guess kind of both? And then how relevant those are to some of the murine studies, like if the murine models will have sort of translation here where you can look at sort of similar types of biomarkers.
I think maybe we'll just focus on the early stage. So in the stage, I think it doesn't make, even you get diagnosis, so it's probably too late. So we'll focus on the early stage of biomarkers development, especially MCI. Also, we have, I think for the differential diagnosis, the AD, compared to the autopsies, we have several very good ones. So.
I'm one of the non-basic science research expertise people. So can you help me understand how you're using brain tissue from
Yes.
deceased patients? So my guess is that they would be in a more advanced stage. How are you able to find biomarkers from mild cognitive impairment from that brain tissue? I may have missed something.
We have some brain samples from them. Yeah, it's limited number. We only, right now, we only 10.
Mhm.
Yeah. Probably they die from some reason, I don't know.
Okay.
Diagnosis MCI yet.
Oh, so they had a diagnosis of MCI.
Yeah, maybe die
And
for
they
some
passed
other
away.
reason.
Okay.
Yeah. Yeah, that's why I can get the early one. So only
Gotcha.
why also limited number.
Right. Okay.
It's this area, this period maybe is 2 to 10 years, even longer.
And so the goal is to work towards being able to use blood samples to look at the same
Yes.
biomarkers?
Yes, that's why we need a more sensitive method.
Right.
Yeah, first for current method, we only can detect the in the brain tissues. Brain tissue, of course, it's not ideal. It's post-mortem, so.
Thank you. That was helpful.
Yeah, thank you.
What sort of problems do you anticipate with your studies? You know, I think it's always helpful to think ahead to try to anticipate difficulties that you'll run into as you proceed. Have you thought about things that might occur to derail you?
Some of the samples, like the MCI samples, we only are 10 right now. So we are not sure we can get the, more samples. So we need a collaborate with the other institute to seek for more samples. For the method parts, I think the similar technique is pretty mature right now. So we already contacted the company people to come here 2 times already. So should not be a problem in this time.
Did I see Susan's hand up?
No.
Sorry.
No.
All right. Well, if we don't have any additional questions, I guess first I want to thank our 2 rec scholars who presented today. I'm looking forward to your presentations again at the Slam Dunk, and we're really excited to have you join us as part of the rec, and look forward to helping you get this research accomplished and supporting you however we can. I don't know if Jan or Karina wanted to make any comments about Slam Dunk stuff. Maybe it'd be good to give a reminder about the registrations and those items.
I'm gonna let Karina get us back up to speed on that.
Yeah, so we sent a reminder about registration around on the Ideas Forum listserv. I will send that out again. It has a link to the Qualtrics survey that we're using for registration. If anyone would like to receive that and is interested in attending the Slam Dunk and are not on the Ideas Forum listserv, please just chat in your email address and let me know if you want to be added to the Ideas Forum listserv. I will add you if you want that, or just send you the registration link.
Yeah, we think it's going to be outstanding. Lots of great presentations, and lots of networking, which is also part of our goal. Does anybody have any questions about that? And I think we're at the hour, or a little past, and I just want to thank everybody for taking their time to come to our ideas forum and for great presentations, practice for our scholars, and really appreciate all the input that everyone can give, and look forward to resuming this after our Slam Dunk Conference next month. So you'll be hearing more about that as reminders as we get closer to the date. And if you have anything you want to bring up or any questions about the forum or any new ideas, then please do not hesitate to contact Karina, me, Kyle, Dayami, Dr. Binbar, and Dr. Roberson, and let us know. Because we really, again, want to share research in various stages. And what we think is great about this group is that we have, you know, wide spectrum of backgrounds here. And that's what we hope that will help make all of this research very translational and very interactive. So just want to thank again our presenters and all of those of you who joined us on the call. So thanks so much, and we look forward to seeing you next month. Slam dunk.
And one thing we didn't mention explicitly, but there is no registration fee for the slam
Important.
dunk.
Very important.
Especially for
Karina.
those graduate students who have limited budgets. It's
Yes.
it's free to attendees.
That is the best final word to end on. Thanks, everybody.
Thank you.